Thank you, Dr. Delrubai and Dr. Ariari for inviting me for this talk. My talk today is about characterization of standing balance and walking stability after spinal cord injury using wearable systems. This talk is about my clinical research, one of the clinical research projects that is indeed the application of wearable technologies that we developed in the lab. I hope this talk would be interesting for those interested in clinical engineering research and knowing about the application of wearable technologies that engineers can develop. A little bit about myself. My research is about human motion biomechanics, design of biomedical instrumentation, and particularly wearable sensors. We do work in my research lab with a state-of-the-art technology for human motion biomechanics and motion capture. The applications that we are interested in are biomedical engineering, rehabilitation engineering, athletic performance assessment, and athletic injury prevention, and finally, ergonomic risk assessment in order to have safety at workplaces. What we are interested in our research lab is not only the development of wearable technologies, but also the clinical application and the implementation of these technologies in clinical or in general real-world applications. What we are interested in is the cycle that you can see here. We always like to start from a real need or a need in the real world that would require modeling and technology development. But we are aware that biomedical technology that is developed in the lab should be validated also. This validation would have two phases. One phase is the in-lab validation, which can also be called technical validation. The purpose of technical validation is always having the accuracy of the developed technologies validated versus gold standard reference systems. In addition, and in the next step, what's important is to have in-field validation of the technology, which is validation of the technology in typically clinical studies. After these two phases of technical and clinical validation, or in lab and in-field validation, we can move forward toward implementation of the device and transfer of technology for commercialization and having it available for the public use. Today, I want to talk about a few technology solutions for spinal cord injury, but you will see that same technology can be well used for other neurological or even maybe orthopedic conditions. Spinal cord injury particularly is a condition that affects every year something like 4,000 individuals in Canada and around 18,000 individuals in the United States. The total number of individuals living with a spinal cord injury in Canada is about 86,000 and just less than 300,000 individuals in the United States. So 86,000 in Canada and less than 300,000 in the United States. What happens in a spinal cord injury is that the loop that we see here, gets affected with injury. So in this loop, we see that human motion, especially human body sway, is sensed by body sensory systems, which are typically vision system, vestibular system, proprioceptive system, and somatosensory systems. The information is processed in the central nervous system that is composed of brain and a spinal cord, and the central nervous system regulates the activation of the body musculature in order to regulated standing or sitting, and in general balance and locomotion of the individual. So in the case of a spinal cord injury, we see the injury at the level of a spinal cord that would affect the performance of this closed loop system and would impair the function of this closed loop system. So the outcome can, of course, be the total loss of connection between the central nervous system and human body, at least some parts of the human body musculature, such as lower limbs, but mostly maybe 95% or more than 90% of times, this loss of connection is simply incomplete. It's not complete, it's incomplete, which means that there is some sensory motor function of the body or affected parts of the body. So the result is that the individual would be able to regain his or her partial balance and walking ability after the first year of injury. So with this good hope that after 1 year post-injury, the individual can walk with some walking aid like walker, cane, or whatever, one can feel very optimistic, but we do not see many individuals with a spinal cord injury walking. And the reason is that the challenge they have in maintaining their standing or sitting balance while recovering their walking function. That would result in the loss of balance, that would result in falling. Around 78% of these individuals able to walk after a spinal cord injury fall at least once a year. So these falls could be very dangerous because according to some stats, we see that 67% of such injuries, they require treatment in emergency services of hospital, or sometimes requirement for staying in hospital between 1 or 2 months, right? The total cost of fall-related injuries, not only just because of the spinal cord injuries, generally fall-related injuries across Canada is estimated around $2 billion a year, which is simply a lot if we want to see it in economic aspect. Anyway, we want to prevent such falls. But the other issue is that even if the individual doesn't fall, the fear of falling can really impact the social activity of the individual and impact the community participation of individuals. Now, in the time of COVID-19, we can really see what are the what are the consequences of lack of participation in the community and social activities. We can see all different range of physiological or psychological consequences of such limitations. So we really need to not only prevent falls, but also fear of falling. Now, let's see how we can assess such risk of falling and how we can help with rehabilitation, typically physical therapy, in order to minimize such risk of falling. Historically, we use clinical functional tests such as gait balance scale test in order to assess the risk of falling and in general balance of the individuals. What it composes is that we ask the individual to stand, sit, walk, sit to stand, and a range of typical activities we have during daily life. And the therapist can record the performance of individuals and assign a score, which is for the case of gait balance scale out of 56. And based on that, they can assess the standing balance performance or in general balance performance of the patient. They can compare such performance before and after a course of physical therapy, and then they would be able to assess the impact of the treatment. The key issue with such clinical functional tests are that they are subjective. They have poor reliability, which means that sometimes test-retest reliability for such tests are not high enough, and they are not much sensitive change. The other side of the spectrum is what we call the instrumented test. For example, we use we can use motion capture cameras and or force plates um, in a motion lab in order to precisely um, assess the balance performance of individuals. Then the challenge for such setups that they're expensive, they require dedicated lab, and they require much time for subject preparation and also data processing, which would limit a wide range use of such technologies for every patient. So ideal solution would be some instrumented functional test in a way that we can have the functional tests such as weight balance scale, and at the same time we can measure balance performance out of lab using some sensors. Ideally, we want to use wearable sensors that minimally affect the clinical procedure. Essentially, we expect to have same clinical functional tests conducted by the therapist, but without requirement for expensive equipment and also dedicated lab space, and also having technical staff ready at hospital. So let's summarize what we have. The problem is that we would like to have instrumented balance assessment that can be simply integrated into clinical functional tests. If we can have such technology, we can use this technology in preventive and rehabilitative strategies for reducing risk of balance. Also, we can use them for objective outcome evaluation of physical therapy. So objective of our study, according to the cycle that I showed you in the second slide, was that we need to validate such technology for its accuracy and also validate it as a clinical tool. I'm not going to talk in this presentation about details of development of such technologies that requires another presentation probably, or a series of presentations, but please assume that we have already developed such wearable technologies for standing balance and walking stability assessment. Now we want to validate the accuracy for measurement of standing balance, and we want to see how such technologies would be validated for clinical studies. So I'm going to talk in this presentation about the outcome of 4 of our published papers. I'm going to talk about the validity of the wearable technology that we are going to use. Then we are going to talk about their application in characterization of standing balance after incomplete spinal cord injury, and characterization of postural control, especially interjoint coordination after incomplete spinal cord injury. And finally, we want to see how a similar technology can be used for walking stability assessments after incomplete spinal cord injury. So starting with the first phase, I'm going to talk about the outcome of a paper titled Validity of Using Wearable Inertial Sensors for Assessing the Dynamics of Standing Balance, that is currently published in Medical Engineering and Physics. In this research, we involved 10 able-bodied individuals. They were typically young and with no history of neurological or orthopedic conditions. We asked them to stand 2 minutes on a force plate in blue that you can see in the figure. There were markers placed on the anatomical landmarks of the body, and inertial sensors were placed on the tibia, which is the shank, sacrum, which is the pelvis, and also sternum on the trunk of the individual. So we used a multi-segment model of the body composed of trunk, pelvis, leg, and foot. We used assumption of bilateral symmetric body motion, which would require placement of the sensors on one half of the body, the left or right. Then using the algorithms that I'm going to briefly talk about, we measured the joint angles of the individual using both IMUs, inertial sensors, and motion capture cameras. Also, we measured joint moments and center of pressure using a combination of force plate and motion capture cameras, or only using IMUs. Briefly speaking, what we did using either only accelerometer or accelerometer plus gyroscope, we assessed the orientation of each of the segments of the multi-segment model of the body that we can see in the figure. Then we used top-down inverse dynamics in order to measure joint angles and center of pressure. After doing that, once with accelerometer only, and then using accelerometer plus gyroscope, we used the same approach, but used the data of motion capture cameras in order to find center of pressure and joint moments. And finally, we used the combination of motion capture system plus force plate in a bottom-up inverse dynamics approach to find center of pressure and joint moments of the body. The idea is that we want to compare the joint angles, joint moments, and also center of pressure obtained by a wearable sensor and compare them to the ones obtained using only camera or camera plus force plates in order to have the accuracy of inertial sensors in measurement of these parameters. So here we have some results. We see that the joint angles obtained on the mentioned multi-segment model of the body, they were accurate in a matter of, you see with the accuracy of much less than 0.5 degrees. Also, we see that the errors obtained for joint moments in the sagittal and coronal plane when the joint moments were obtained only with inertial sensors were comparable to the errors of camera only when we have the errors against the gold standard reference system, which is force plate plus cameras. Also, we see that the trajectory of center of pressure obtained by IMUs is very similar to the ones that we can obtain with force plate. The other interesting aspect is that doesn't matter if we use a combination of accelerometer plus gyroscope or only accelerometer, the errors are comparable. So it means that for this particular motion, maybe the use of accelerometer only would be sufficient. So in summary, the conclusions of this study were, first of all, there is no significant difference between the values of joint moment, joint angle, and center of pressure when we use accelerometer only or we use accelerometer plus gyroscope. Also, there was no significant difference between the values obtained with IMUs and the ones obtained with motion capture cameras. We also noticed that the joint angles and joint moments obtained by IMU, typically only accelerometer, had very small errors and high correlation with the values obtained with the reference system, and thus it proves the suitability of accelerometer only for finding dynamics of a standing balance. Why accelerometer only is preferred? Because it can have a number of advantages compared to accelerometer plus gyroscope. The main reason is lower power consumption and lower price. In a technology that we are going to use in the next slide for balance assessment, we can just use accelerometer. Now, let's talk about the second part of validation. And I'm going to right now talk about the outcome of the published paper that you can see here, which is titled Characterization of a Standing Balance after incomplete spinal cord injury, especially alteration in integration of sensory information. The work is published in, it's going to be published, it's available online in Gait and Posture. So in this study that was, the data collection was conducted at Toronto Rehab Institute, Linter's Health Center in Toronto and also University of Montreal. We involved, here we see 8 individuals with a spinal cord injury, 4 individuals with paraplegia, and 4 other ones with tetraplegia. They had either traumatic or non-traumatic spinal cord injury. The condition was having more than 5 months after injury, and also they were all motor incomplete spinal cord injury with Asia scored C or D. They were all able to walk, of course not with perfect balance, but without any assistive devices. We also involved 12 individuals. They were 12 age match able-bodied individuals. We asked each participant to have quite a standing in 4 conditions, which were standing on a hard surface with eyes open, on hard surface, eyes closed, on a foam surface with eyes open and with eyes closed. For the case of incomplete spinal cord injury group, we repeated the test after 2 weeks to have retest results in order to measure, in order to assess the test retest repeatability of the measurements, but I'm not going to talk about the outcome in this talk. We used the technology that I described in the first paper in order to have a number of parameters describing time domain and frequency domain characteristics of center of pressure and acceleration of the body. We used information of only one sensor on the sacrum. So this study required only one IMU placed on the sacrum. It's important to know that with these range of parameters, which are time, frequency, domain parameters describing center of pressure excursion and also center of mass sway of the body, we would be able to have the parameters that can describe the stability performance of closed loop control system for standing balance, the postural regulation of the balance, and control demand in terms of muscular effort for maintaining a standing balance. So let's see the results. Here in the results, you can see the results of individuals with incomplete spinal cord injury in box plots showing shown in red. The performance of able-bodied individuals in black. Also, we see the results of different sensory conditions with eyes open or eyes closed, or standing on a hard surface or foam surface. In summary, if I want to explain how these representative parameters related to excursion of center of pressure can describe, we can in general see that we have, of course, better performance individuals that are described as healthy or able-bodied, described with the sign AB. You see with AB individuals or able-bodied individuals, we have better balance performance, which is totally expected. What we see is that performance in general for both groups on hard surface is better, and also performance with eyes open, they are better. These are all expected. They could expect all of them. However, what is super interesting here is that the effect size of change of surface condition, which means standing on a surface, was larger for able-bodied individuals compared to spinal cord injury group. So it means that able-bodied individuals were more sensitive for the balance, standing balance, when we asked them to stand on the foam. In contrast, the effect size of vision condition was larger in spinal cord injury group, which means that individuals with spinal cord injury were more affected with closing their eyes, right? So we were able to see the same trend in center of mass parameters, and especially with the acceleration of center of mass. We again could see that based on acceleration parameters, we can see larger effect size of surface condition for able-bodied group and larger effect size for vision condition in a spinal cord injury group. What do we conclude? We conclude that first of all, a single IMU on the spectrum is able to distinguish individuals with incomplete spinal cord injury from able-bodied individuals. And also we were able to see reduced standing balance stability performance. We could see increased control demand and less effective active correction for individuals with a spinal cord injury in all standing conditions. Most importantly, we were able to see that participants with incomplete spinal cord injury relied more on the visual information compared to somatosensory information, in contrast to able-bodied participants. That can have a clear physiological explanation because individuals with spinal cord injury, they have impaired somatosensory information. They have less sensation or less trust on the information they can collect with the foot sole about the stiffness of the surface. Because of very same reason, they try to rely more on the vision information that is impaired. However, individuals without any condition, able-bodied individuals, they use both sensory systems for maintaining their standing balance. And as such, they are more sensitive compared to spinal cord injury group to the change in somatosensory information reliability. So that was interesting because only with one single IMU in the clinical setting, we were able to discover or confirm such physiological phenomena. The conclusion was that instead of having patients going to the lab while they're going through the normal clinical functional test, we are able to have such precise and sensitive assessment of their standing balance. But what if we want to have some objective assessment of standing balance in terms of interjoint coordination? So what I'm going to talk about is the outcome of our recently published work titled Postural Control Strategy After Incomplete Spinal Cord Injury and Effect of Sensory Inputs on Trunk Leg Movement Coordination. The work is recently published in the Journal of Neuroengineering and Rehabilitation. So here you see that we have modeled the human body with three segments: the feet, the leg, which is composed of the shank and thigh. So essentially, we ignore the motion of the knee during standing balance or during quiet standing, I'm sorry, and also the trunk. Now we consider trunk, arms, head as single segments. So we placed one sensor on the shank and one on the sacrum for kinematic and kinetic assessment of this multi-segment model. The idea is that during quiet standing, we use the motion of both ankle joints and hip joints in order to maintain a standing balance. In the previous study, ignored the contribution of hip joints, but in this current study, the objective is to see how postural control via trunk leg movement coordination can be different between able-bodied group or controlled group and incomplete spinal cord injury group. Now, we can see that the interjoint or intersegment motion coordination of trunk and leg can be regulated using the muscles that induce torque in the ankle and hip joints. We are particularly interested in seeing the effect of sensory information or impairment of such sensory information on trunk leg movement coordination. For this purpose, we used an index that we used the first time with IMUs which is indeed magnitude squared coherence of the trunk and leg anterior-posterior acceleration. So coherence measure is a measure for frequency analysis. You have probably heard about it, or you have seen it already in different courses, signal processing or other courses. In general, we want to see how two time series would have a similar frequency content or frequency characteristics. In this particular case, we want to see the coherence between the trunk and leg anterior-posterior acceleration. Particularly, we were interested in assessing such coherence in the frequencies less than 1 Hz, because it's shown that in this low frequency motion, the ankle strategy for standing balance control is the dominant strategy, and also in high frequency, which is frequencies larger than 1 Hz, where a mixture of ankle and hip strategy regulates a standing balance. In a similar setting, which was indeed similar data collection protocol, we collected data for both groups of spinal cord injury and able-bodied controls using this time 2 sensors placed on the sacrum and on the tibia. Here we see the results. With these results that show the coherence indeed, we can see the coherence for both groups in 4 conditions that are standing on hard surface, foam surface with eyes open and eyes closed. We can see the results of coherence in red for spinal cord injury group and in blue for able-bodied controls. And we can see the results in the form of mean plus minus standard deviation for each group. Summary of observation is that low frequency oscillation, which represents the ankle motion strategy, we see that the performance of 2 groups are similar. However, for larger frequencies that represent the mixture of ankle hip strategy, we see that we can see difference between the performance of the groups, both groups in different environmental conditions of surface and vision. Of course, we see that individuals with a spinal cord injury, they have larger coherence in high frequency. So this larger coherence means that still they use the ankle more than ankle hip strategy, which means that they have more impaired ankle hip strategy for maintaining a standing balance. But what is more interesting is that we can see that individuals with, let me go back to the previous slide, individuals with able-bodied, individuals with incomplete spinal cord injury, they have different strategy in different condition also compared to able-bodied individuals. So I summarize the message. 1, individuals with spinal cord injury, they have larger coherence in high frequencies, which means that further impaired ankle hip strategy for maintaining a standing balance, and also the performance of the 2 groups in different surface and vision conditions are different. So, summary of this study, we noticed that we can see similar balance strategy at lower frequencies for incomplete spinal cord injury group and able-bodied controls. Also, we noticed decreased ability after spinal cord injury in adapting intersegment coordination, changing from ankle strategy to mixed ankle hip strategy as the sway frequency increases. Then we noticed alteration of somatosensory inputs can affect the leg trunk motion coordination in both populations. And finally, probably most importantly, at least for engineers, we noticed that our introduced parameter, which is magnitude squared coherence, of the trunk and leg accelerations would have sufficient sensitivity, discriminatory ability, and excellent test-to-test reliability for standing balance assessment. What I did not explain here, what you can see in the paper is that coherence parameters had far better retest repeatability compared to the parameters that I explained in the previous study, which simply described the center of mass and center of pressure sway of the individuals. And as such, they are preferred for clinical evaluations. Now, in these two studies, I did talk about the standing balance. Now, let's briefly talk about the use of wearable sensors for walking stability assessment after incomplete spinal cord injury. And that would be the results of our other recently published paper titled using wearable sensors to characterize gait after spinal cord injury, a psychometric study. So this work is the last work I'm presenting here and is published in Spinal Cord, which is one of the main journals in the field of spinal cord injury evaluation. A brief summary, as I formerly explained in one of the first slides of this presentation, we know that a majority of individuals with spinal cord injury, indeed with incomplete spinal cord injury, can at least partially recover the walking stability. However, a big portion of them fall at least once a year because of the impairment of balance. Then we noticed that IMUs, or wearable inertial sensors, they have potential to assess motion, movement disorders, and also to detect incidence of falling. But before our study, there was no study that assessed their ability in quantification or characterization of walking stability after spinal cord injury. We noticed that based on the literature, they can measure gait parameters related to gait stability, but again, they were not tested for the case of spinal cord injury. So the outcome of this clinical research was to compare gait stability performance between two groups, which were incomplete spinal cord injury group and able-bodied controls. Same data collection procedure. We involved 21 individuals with a spinal cord injury, plus 19 age-matched able-bodied participants as control. We collected the data in both sites, in Toronto and Montreal. Here we had 5 walking conditions, 20-meter walking conditions, on hard surface and foam surface. This time we attached foams beneath the shoe sole of the individuals, and they were asked to walk with normal vision and reduced vision. For the case of reduced vision, we asked them to wear glasses that had a blurry surface, so their vision was blurred, reduced vision in a level that it was still safe for them to walk. And they had a 5th condition, which was dual task. In this dual task, we asked the individuals to walk in normal surface and vision condition, but just ask them to name months backward in their mother tongue, either English or French, to have the effect of dual taskings in their walking stability. We measured a number of gait parameters, but in this presentation, I'm just going to talk about the cadence, which is number of steps per minute for these individuals in 20-minute walking, in 20-meter walking trials. And we presented their cadence in the form of interstride average of cadence plus interstride variability of cadence, described with a mean value and coefficient of variation of cadence during these 20-meter walking conditions. So I talk about the results. I talk about test-to-test repeatability of cadence here, quantified based on ICC, interclass correlation. Based on previous research, we considered ICC more than 75% as excellent retest repeatability. The values between 40% and 75% as moderate, and less than 40% as poor. Now we see that in a majority of conditions, either of mean value of cadence or the coefficient of variation, or both of them, had excellent retest reliability, or rarely they had a moderate reliability. And also, we showed convergent validity of cadence based on the correlation of cadence or its interstride variability with two well-established clinical scores. And we noticed that in a number of our walking conditions, we had significant correlation of cadence and its interstride variability that shows the at least partial convergent validity of these scores for walking stability assessment. Now let's see the responsiveness of cadence and its interstride variability for assessing walking stability after spinal cord injury. Now, in these complex graphs, you see the performance of able-bodied controls and spinal cord injury group in different walking conditions. And you can see that here we try to find significant difference between the cadence and interstride variability of cadence in different walking conditions of both groups. Summary of findings. We noticed that individuals with spinal cord injury, they had a smaller mean of cadence in all conditions and larger interstride variability of cadence compared to able-bodied group. Individuals with spinal cord injury, they showed larger cadence in normal condition. By normal, I mean hard surface and eyes open, without dual tasking. They had better cadence, which means typically faster pace of walking, smaller stride variability of cadence compared to other conditions, which is again physiologically explainable. In able-bodied group, we could see that the mean cadence was a better parameter for assessing walking stability compared to interstride variability of cadence for characterization of walking stability under various conditions. And maybe most importantly, we noticed a significant between group difference that existed only based on variability of cadence for foam surface and foam surface plus impaired vision condition. What it means is that it's not sufficient to measure gait parameters for assessment of walking stability in a spinal cord injury group. We should also notice variability of gait parameters, which would be an indicator of walking stability to have better understanding of the impact of a spinal cord injury on walking stability. So let's see what is the conclusion. In conclusion, cadence extracted from wearable sensors placed on the individual's foot and or shank can detect between group and between condition differences during walking under various walking conditions. We noticed that interstride variability of cadence is a useful parameter, useful tool for characterization of posture control during walking for individuals with spinal cord injury. We noticed that walking on compliant surface or foam surface is more challenging for spinal cord injury individuals compared to able-bodied controls. And finally, we noticed that cadence and its interstride variability has high test retest repeatability and significant or acceptable convergent validity for walking stability assessment after spinal cord injury. So at the end of my talk, I'm going to summarize our findings. We noticed that technical validation of the wearable technologies that we do develop against in-lab instrumentation is needed before using the wearables for clinical research. We noticed that accelerometer-only solution is sufficient for standing balance assessment. We noticed that for the case of a standing balance, quite a standing balance, individuals with spinal cord injury were more affected with vision impairments, and an able-bodied control group were more affected with somatosensory impairments based on walking on the foam. Also, we noticed that the spinal cord injury group were affected they had affected multi-joint motion coordination during a standing balance. These impairments was in the form of reduced ankle hip strategy during the standing. So we noticed that for discovering such change, we require the use of multiple sensors on the body and complex time frequency analysis. We also noticed that, sorry, I have a typo here. We noticed that spinal cord injury group, they performed different compared to able-bodied controls in various walking conditions, since the reliance on vision and on somatosensory information was different compared to able-bodied group. If I want to summarize this effect, I can say that individuals with spinal cord injury, they rely more on vision compared to somatosensory systems, which is expected. The next step, future perspective, would be conducting such a walking and balance test on the different conditions for Fowler spinal cord injury group and non-Fowler spinal cord injury group, which means that there are some individuals with spinal cord injury that fall more frequently. Now, it would be interesting seeing that how we can characterize the walking and standing balance between these two groups, so that if we can do that, we can identify the change in walking or standing can lead to more frequent falling, or if there is no causal relationship, we can find some correlations that would be helpful for clinical studies and clinical evaluation. At the end, I should thank the help of my colleagues and collaborators in these 4 studies, plus the support of funding agencies for this study. Thank you very much for attending this lecture. I would be happy to answer any questions that you may have.